Professor Goldberg, thank you so much for coming to talk to eCancer TV. It's a very busy German Cancer Congress in Berlin, snow outside, the sun is shining out. What are you doing here? What are you talking about?
Well, it's an exciting meeting. There are almost 10,000 German oncologists here. I had no idea there were so many, and there's so much interest in cancer. So what I'm here to talk about is metastatic colorectal cancer management. And I spent a long time today talking to the group about the interactions between the biologics and chemotherapy. Chemotherapy is still our backbone of treatment for colorectal cancer.
But it's not very good.
Well, it's better than it used to be when you and I started our careers. Back then, when 5FU was all we had,
that was it.
we would show everybody when we had a response.
Yeah.
Now, if we don't have a response, we're disappointed. But the chemotherapy backbones are, of course, being combined with biologics standardly. And trying to sort out, well, what's the best biologic for the best chemotherapy platform, and do you pile everything on at once, or do you use treatment sequentially, is a question that's still open. But there have been some surprising developments in the last few years in terms of interactions of the drugs. So we know from the PACE trial and also the CAIRO-2 trial that took chemotherapy plus bevacizumab and added either cetuximab or panitumumab to it, that more is not always better. And in fact, there was a dramatic decrease in outcomes when you had 5 drugs rather than 3 or 4 drugs. And that, of course, was worse than the patients with the KRAS mutated tumors. But there really wasn't much benefit even in the patients with KRAS wild type. We have an interesting finding that will be coming out at ASCO this year, that in the adjuvant setting, giving cetuximab to patients with KRAS mutated tumors is also harmful. So there's some sort of interaction between these biologics and chemotherapy.
Mediated through
the EGFR pathway.
Some sort,
Through the EGFR pathway. And what that is, we don't understand, but it's a fascinating finding. And I think proves the law of unintended consequences in multi-drug polypharmacy.
Well, you should always do two-tailed tests.
Correct.
For deterioration. What do you think yourself is going on?
Well, I think that there must be some way that EGFR inhibition slows growth of tumors, making the tumors less susceptible to chemotherapy. And I'm not an expert in this pathway. I look to others in the lab who are far more knowledgeable about it than I to help explain this to us. But from an empirical point of view, I think that sort of interaction is occurring.
You couldn't be altering the decision-making of, say, stem cells?
I think you could, certainly. Or you could be altering the pharmacokinetics or pharmacodynamics of the agents, although I think the evidence for that is less clear.
Mm-hmm. So, standard of care remains for metastatic colorectal cancer what?
In my opinion, combination chemotherapy, whether you pair FOLFOX or capecitabine with irinotecan or oxaliplatin. And in the U.S., we're still using bevacizumab in first-line therapy. I recently talked to some oncologists from U.S. Oncology. They've actually made the bevacizumab optional. And so our initial enthusiasm that everybody had a right and had to have bevacizumab, I think has been tempered by some of the studies where there's been no improvement in the response rate and there's been modest change in the progression-free survival when bevacizumab is added to idealized chemotherapy regimens.
Toxicity, an issue or not?
Toxicity is always an issue. The more you add, the more toxicity you get.
Sure.
But I think the Italians have shown us with their FOLFOXIRI regimen that you can give all 3 chemotherapy drugs safely with tolerable toxicity in some circumstances.
So do I take it then that you're now looking more at sequential use of medications?
Well, I'm not a single agent person.
No.
So I seldom would use a single agent.
Must be our vintage.
Right. And so in general, I would use combination chemotherapy, but I haven't yet treated my first patient with FOLFOXIRI. Keep waiting for the right person to come to my clinic, but I haven't found that person yet.